Hello, how are you? My name is Abdullah Bujanambo. I am a CFMG certified physician and applying for a tutor in the match guy. Okay, I will explore the first case, which is cardiogenic shock. So, here is a case of 60 years old man undergo right lung biopsy for a possible diagnosis of restrictive lung disorder. 2 hours later, the patient started to complain of sudden shortness of breath and chest pain, severe. His other medical problems include hypertension and hyperlipidemia and pernicious anemia and inguinal hernia repair 10 years ago. The patient does not smoke, drink alcohol only occasionally. Blood pressure now is 70 over 40 millimeter mercury and pulse is 118 beat per minute and the respiration is 30 breath per minute, which is indication that this patient now in shock, the body in shock. So what kind of shock that the patient suffer from after a procedure with 2 hours? The patient presents with sudden onset, severe shortness of breath, chest pain and hypotension, mainly cardiac, mainly lung, whatever. He's diaphoretic and skin cold, calming. Pupils are equal and react to light bilaterally. Intra-arterial blood pressure monitoring is established and pulmonary artery catheterization is performed, which is give us a clue about the nature of hemodynamics within this patient. Within this patient, initial measurements are as the follow. Cardiac index is 2.3, which is indication, which is low, indication for low cardiac output. So, and pulmonary capillary wedge pressure, which is reflecting the pressure within the left atria. In another word, it is the left atrial filling pressure, 26 millimeter mercury, which is high. And so, what kind of shock? In another word, the question asking me, what kind of shock that leads to sudden chest pain, and after the patient complained of chest pain, shortness of breath, hypotension, tachycardia, but at the same time, the pulmonary capillary wedge pressure, the cardiac output was low, measured by pulmonary artery catheterizations, and the pulmonary capillary wedge pressure is high. It is a classic case of cardiogenic shock. So, what is the possible diagnosis or the possible cause in this case that leads to cardiogenic shock? Because there is wide pathologies that could lead to the cardiogenic shock, like fulminant myocarditis, like arrhythmia, like myocardial infarction, acute coronary syndrome. Okay, which of the following is the most likely diagnosis in this patient? Anaphylaxis. To know this question, exclude effectively eliminating the wrong answer. There is 4 different types of shock: distributive shock, obstructive shock, and cardiogenic shock and hypovolemic shock. And anaphylaxis, septic shock also is type of distributive shock. And distributive shock characterized by widespread decrease in the systemic vascular resistance. There is widespread vasodilation. The arteriole was increased, and this means more blood will be pooling within the veins, and when pooling within the veins will decrease venous return to the right atrium will be decreased. So the pulmonary capillary wedge pressure, and so the right ventricle, so going to the lung back to the left atrium here will be decreased. So the pulmonary capillary wedge pressure in these pathologies will be low. So I will eliminate anaphylaxis and septic shock. Myocardial infarction could be a possible cause, extremely high yield in this topic. Myocardial cause for cardiogenic shock is myocardial infarction, and myocardial infarction, this is the heart, there is ischemia, and there is impairment within the left ventricular function due to ischemic changes and infarction even, and this will impair the cardiac output. This is why cardiac index is low, but the blood will return back to the lung, and so the left atrial pressure will be high, so the pulmonary capillary wedge pressure will be high. So this is the possible answer. Non-cardiogenic pulmonary edema, mainly this is happening with ARDS due to the lung was heavy filtered with fluids, and it is not due to impairment within the cardiac functions. But why? This is mainly because there is inflammation, mainly septic shock, pneumonia, or something like this, and the pulmonary capillary wedge pressure in this pathology will be normal or low. So I can exclude this answer also. BE and tension pneumothorax, those are kinds of obstructive shock, that the function of the heart was very good, but the cardiac output was low, not because there is impairment in the contractile function of the heart, however, because the heart was impeded. There is external compression, there is something obstructing the outward transport of the blood away from the left ventricle to the aorta. So BE, which is mainly present within the right ventricle, it is impeding the blood going to the lung and so back again to the heart, and this will lead to decrease the pulmonary capillary wedge pressure because the amount of the blood going back to the left atrium was decreased. The same thing with tension pneumothorax, because this is the mediastinum. There is compression over this heart, so the compression will decrease the amount of the blood that's going back to the right atrium and the left atrium as well. So this will also associated with decreased pulmonary capillary wedge pressure. However, there is a pathology within the obstructive shock that is associated with high pulmonary capillary wedge pressure despite there is decreased cardiac output, and it is important to differentiate it between this kind of obstructive shock and cardiogenic shock, which is cardiac tamponade. And cardiac tamponade, mainly to explain this is the pericardium, the space within the pericardium. It becomes filled with the blood here, but the amount of the blood compress the heart, so the relaxation to filling the blood, the relaxation expanding of the heart, and the relaxation and filling very well of the blood will be limited, and so the amount of the blood that going to the left atrium will be low, but the pulmonary capillary wedge pressure paradoxically will be high. The main reason for this is because the external compression over the heart, not because of increase the amount of the blood within the left atrium.